Foundations lecture today, and we want to thank Dr. Karat today for speaking on cardiopulmonary interactions. As a reminder for today's session, we'll have the first divided into 3 parts. Our first part will be a presentation, followed by about a 10-minute question and answer portion where everyone is invited to join in, and remind everyone to submit your questions via the Q&A. And then after that, we'll have a case-based discussion where we will just invite the trainees, and that will be in a separate link. Want to thank our sponsors today that we have from Mallinckrodt Pharmaceuticals with an unrestricted educational grant. And as a reminder that we do have accreditation by the Royal College of Physicians and Surgeons of Canada. So with that, I will go ahead and introduce our speaker today. Dr. Karat is a staff neonatologist at Mount Sinai Hospital in Toronto, Canada, and is an assistant professor in pediatrics at the University of Toronto. She obtained a Master's of Science in Healthcare Quality program from Queen's University in 2019. She has a clinical and academic interest in bridging cardiopulmonary physiology with quality improvement, and is currently undertaking research in both neonatal hemodynamics in sepsis and septic shock. Thank you again for agreeing to give our lecture, and excited to hear your talk.
Thanks, Amy, and thanks to the organizing committee for inviting me today. If you cannot see my slides, let me know. Otherwise, I'll go ahead and get started. So I think this is a really important topic. I'm very excited to be discussing cardiopulmonary interactions today. It's typically Danny's talk, so I hope I do him justice. But I've put together this talk really to go over the foundations of respiratory physiology, how hemodynamic principles play a role, and just to give a few clinical examples at the end of things we typically see in the NICU. So the cardiorespiratory system, the ultimate goal is basically oxygen delivery to the tissues. That is the first and foremost biggest responsibility for the heart and the lungs. And it's really a factor of a bunch of different components, which we can see in this formula for oxygen delivery. It's a factor of cardiac output, so a heart component, of hemoglobin, so oxygen carrying capacity, and then oxygen saturation, which is predominantly driven by the lungs. So there's a lot of factors at play just to get that oxygen molecule delivered to the tissues for aerobic metabolism, which is, again, the goal in the end. And we're going to start by talking about lung physiology first. So it's really important to understand that the lungs and the heart, while 2 separate organs, they share the same compartment, and that compartment, ignore that, there's somebody at my door, but that compartment has variable pressures at play. And we're going to start by talking about the mechanics of respiration first. So this is a really important schematic. We'll refer to this over and over again during the course of the presentation. And you can see the separation between the intrathoracic cavity, the intra-abdominal cavity, and then the systemic vasculature. Now, the heart and the lungs both exist within the intrathoracic cavity. They're in the same shared pressure chamber, which is really important because that means pressure is transmitted from essentially from the pleural to the lungs and the heart. And of course, the heart also sits within the pericardial space, which in and of itself has a pressure cavity, but the pleural pressure is typically reflected in the pericardial pressure unless there's pericardial disease. Now, the abdomen is separated by the diaphragm, which means it's its own unique cavity, which means sometimes we can see pressure differences between here, and that's really important to drive normal blood flows. So to understand how this all works, we're going to review basic respiratory physiology first. This is stuff we might have talked about a long time ago, but it's really, really important to contextualize the rest of the discussion. So, of course, as we mentioned, the thorax is its own pressure cavity that has its own pressures that at rest are basically reflected as the intrapleural pressure. This is the difference between the visceral and parietal pleura, and it's essentially reflecting the pressure gradient that prevents the lungs from recoiling and the chest from expanding outwards. It's what keeps everything at balance. The lungs themselves are not homogeneous in terms of pressure. There's variation in pressure between the apex and the bases, the apices and the bases of the lungs. So apical alveoli tend to be more maximally inflated, and basal alveoli are not as maximally inflated and therefore have capacity to change or capacity to be recruited. So during inspiration, what happens normally is the diaphragm starts to contract, as well as the accessory muscles of the chest. They start to contract, and this generates an a negative pressure within the pleural space. So drives, once the diaphragm moves down into the abdomen, drives the pleural pressure to be more negative, and obviously as a consequence increases the pressure within the abdomen. That intrapleural pressure, that negativity is what drives air to go from the outside into the lungs. So that's what causes inspiration. And this happens until there's equilibrium between the pleural pressure and the atmospheric pressure. And that's the end of inspiration. At expiration, the diaphragm starts to rest and the accessory muscles start to rest. They return to their basal tone. And so there's a rise in intrapleural pressure, which forces that exhaled air out. And this occurs until the end of expiration, when atmospheric pressure is equal to alveolar pressure. So this process happens over and over and over again. Now, that is in a spontaneously breathing patient, which means it is driven by negative intrathoracic pressure. This is very different from positive pressure ventilation, which so many of our babies are exposed to. So this is a really nice schema from Satyen, who has highlighted the difference between spontaneously breathing patients on the left and then positive pressure on the right. And as I mentioned, the driving factor in spontaneous respiration is that negative intrathoracic pressure that exists, versus in positive pressure ventilation, the patient is unable or insufficiently able to create the negative intrathoracic pressure that's needed for adequate oxygenation and ventilation. So the baby is attached to a ventilator, which provides positive ventilation. This increases intrathoracic pressure. So it's the opposite of what happens in spontaneously breathing children. Once the intrathoracic pressure is sufficiently increased, that opens up the lungs and that forces the diaphragm down. So you still have an increase in intra-abdominal pressure from that diaphragm moving down, but the thoracic pressure gradient is different from how it is in spontaneous ventilation. Again, this is very important because it plays a role in hemodynamics. So this happens on like a global lung level, but the lung, again, is not homogeneous. It's different. And sick lung is not homogeneous, of course. Different parts of the lung can be affected in different ways. And this was really nicely illustrated by West. If you've never, I put the book on the bottom left there. It's West Respiratory Physiology. It's like mandatory reading for critical care people. Everybody should have a copy of this. But what West described are these different zones depending on the relative pressure gradient between alveolar pressure, arterial pressure, and venous pressure. So we're going to go through these because they're really, really important to understand normal respiratory physiology and normal blood flows through the lungs. So West Zone 1 is when alveolar, big A, alveolar pressure exceeds both arterial pressure and venous pressure. So we can see this really high alveolar pressure situation, so high that it can actually compress the capillary, the surrounding vasculature, and it's a no-flow situation there. We know this as dead space ventilation. Basically, it's ventilation without perfusion. And we see this when we have excessive PEEP, so those really crazy hyperventilated, hyperexpanded kids. Or we can see it when we have really low arterial pressure, like the shock babies, septic shock neck, et cetera. So this is suboptimal, obviously, for oxygenation ventilation. West Zone 2 is an intermediate state, is when arterial pressure exceeds alveolar pressure, but alveolar pressure is still higher than venous pressure. So blood flow will only happen intermittently. It will only happen during the arterial time or during systole. Because alveolar pressure exceeds venous pressure, there's no blood flow during diastole. So it is a suboptimal state, but at least you have some perfusion occurring throughout the cardiac cycle. And then West Zone 3 is when both arterial and venous pressure exceed alveolar pressure. So this allows for continuous blood flow throughout the lung. Most of the time, most of the lung looks like this. And this is why we're able to obtain when we're able to obtain a capillary wedge pressure. Obviously, we can't do it in our babies, but in older children and adults, they're obtained through optimizing that West Zone 3 because there's a continuous column of blood and they're able to obtain a capillary wedge pressure for pulmonary hypertension estimation. There's also this kind of quiet West Zone 4, which I've just put in the bottom there. It also factors in interstitial pressure, which is essentially pulmonary edema situation. So arterial, venous, and alveolar pressure are normal, but there is, for some reason, elevated pressure within the interstitium. And that also affects perfusion and gas exchange in babies. Usually in the NICU, pulmonary interstitial pressure is elevated because of other things. So really, it's a multifactorial problem. So we've reviewed respiratory physiology. Now we're going to talk about how hemodynamic principles that we've talked about in many of these sessions before are impacted by ventilation, both spontaneously breathing and mechanical ventilation. Let's start with preload, because in my mind, it's like the start of the cardiac cycle. So preload by echocardiography, of course, we estimate as end diastolic volume. But from a right-sided perspective, it's really a reflection of systemic venous return. And systemic venous return is determined by blood coming from the extrathoracic great vessels and predominantly the IVC, as well as the RA pressure. So how this works, if we go back to that diagram that we see on the right-hand side, the extrathoracic great vessels are sitting, the IVC is sitting within the abdomen, so is subject to the intra-abdominal pressure. And the right atrium is sitting within the pericardium, within the thorax, so it's subject to the intrathoracic pressure or the pleural pressure. And it's the pressure gradient between here and here that drives that blood back to the heart during inspiration. So in spontaneous ventilation, like we talked about, pleural pressure goes down, intra-abdominal pressure goes up, and as a result, there's a bigger gradient between the IVC and the RA, which really drives blood back to the heart. And so we can see in spontaneously breathing infants that right heart preload is increased during inspiration. And of course, the opposite occurs during mechanical ventilation, because as we talked about, mechanical ventilation, we don't see that negative intrathoracic pressure as we do with spontaneously breathing children, because we're providing positive pressure. So as a result, that RA pressure is higher, and the gradient between the RA and the intra-abdominal pressure is not as significant. So we still obviously get right-hearted preload during mechanical ventilation. It doesn't impede it, but the amount of preload seen during inspiration is not the same as in spontaneously breathing children. I've just put this up to highlight that was a very kind of simplistic, all things the same type of explanation about the relationship between ventilation and preload. But obviously in our patients, especially when they're critically ill, there's multiple things going on that can affect systemic venous return. We just don't have enough time to go through all of these. So then what happens? So the right heart is filled either in a spontaneous breathing or mechanically ventilated child, and now you have this RV that's got blood in it. In a spontaneously breathing child, we have lots of RV volume. Remember, it's augmented during inspiration. So all that volume has to go somewhere. It ends up pushing the septum into the left side of the heart. So there's leftward shift of the intraventricular septum. And that can appear LV filling because LV isn't given the space that it wanted to fill. This is something called ventricular interdependence. We've heard about this before, and it's basically reflecting the shared myocardial fibers between both sides of the heart, and the fact that the heart exists within an enclosed space within the pericardium. So during spontaneous breathing, lots of extra blood comes into the right side of the heart, which can impact LV filling. Mechanical ventilation, remember, the RV doesn't get as filled as dramatically, so you have less of an impact on the septum and less of an impact on LV filling. So you shouldn't have that dramatic change in LV stroke volume, except mechanical ventilation is a bit complex because this is assuming that you have set the settings and the baby's getting the exact settings that they need. Don't forget that with mechanical ventilation, we can dramatically alter pressures within the thorax if we have hyperinflated the lung. So lung hyperinflation can cause constraint on the heart, so that can impede LV filling. Lung hyperinflation can cause increased PVR, which can affect RV function or RV filling pressure, so that can impede RV filling. So it's not quite that straightforward. So all this to say that mechanical ventilation can affect RV filling and LV filling, but even more dramatically if the patient is not at FRC. Okay, let's talk about afterload now. We'll split this up to RV and LV afterload. So RV afterload is determined primarily by pulmonary vascular resistance, which in the lung is essentially determined by intraalveolar and extraalveolar vessels. It's two compartments of pulmonary blood vessels, and they're really important and very different. So intraalveolar vessels are the ones that run along the alveoli, and when we break down the single alveolus, we think of it like the alveolar capillary unit, but they're running along the length of the alveolus. That means that how their vascular resistance is very impacted by how expanded that individual alveolus is. So when you have a high lung volume, a very well expanded alveolus, that will push on that alveolar vessel, intraalveolar vessel, and it will increase the pulmonary vascular resistance because it's squishing it. Conversely, if you decrease the intraalveolar volume, it will allow for decreased PVR because you've opened up that vessel. Extraalveolar vessels are running between the alveoli, so through the interstitium of the lung. They're not immediately connected to each alveolar unit. They are kept open by traction, so basically opposing forces keeping these blood vessels open. So their PVR state is the opposite of intraalveolar vessels. When you have a high lung volume, you basically have opened everything up. That's pulling against the extraalveolar vessels, and that's decreasing their pulmonary vascular resistance because it's really opening them up. Versus if you have a low lung volume, you're kind of kinking these blood vessels, and that will increase their pulmonary vascular resistance. So it's opposing effects with lung volumes and vascular resistance determined by both of these types of blood vessel groups. And the net PVR is a function of both of those two things. So this graph describes this beautifully. I think we've probably all seen a version of this graph in one way or another, particularly that red U-shaped graph. So as we just talked about, alveolar PVR or intraalveolar pulmonary vascular resistance is really is lowest at residual volume, so when the lung volume is low, and highest at total lung capacity, so when the lung capacity is high. And extraalveolar PVR is the opposite. So the combination of these two creates this U-shaped curve of total PVR. And you can see that the nadir of that curve is at functional residual capacity, which is really the ideal place of how we're ventilating our babies. And when babies are spontaneously ventilating and they don't need lots of support, they should be doing that on their own. But it's more complex when we are in charge of determining what settings for their specific physiology, which can be very dynamic. Our entire goal with that is to try to establish FRC because that's their optimal pulmonary vascular state. LV afterload is a little bit different because the left ventricle pumps into the aorta, and the aorta leaves the thorax and is responsible for pumping blood throughout the entire body, versus the pulmonary artery, which is really is a lower pressure vessel, and it's really only pumping to the lungs, which is also within the same space. So both the heart and the lungs are in the thorax. So LV afterload is proxied or related to wall stress, which is the force that acts against the myocardium, the left ventricular myocardium. And essentially, this is the pressure that the heart must overcome in order to be able to eject blood into the aorta during systole. So again, like I mentioned, this is different from right ventricular pressures because the aortic pressure is much higher than the pulmonary arterial pressure. And left ventricular wall stress is governed by the law of Laplace, which is really important for us to understand, again, how the heart and lungs interact from a left ventricular afterload perspective. So I'm going to take a moment to explain this a little bit, or to review it a little bit so that it's clear. The Laplace law is written right there. Left ventricular wall stress is a reflection of left ventricular pressure and radius, and inversely proportional to the left ventricular wall thickness. So let's say we have a normal heart, which for simplicity's sake has a radial unit of 1 and a thickness unit of 1. And we see two remodeled hearts. So these are adult terminology, although we have similar, physiologies, but of heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. But we see concentric remodeling here, which is left ventricular hypertrophy. And we see eccentric remodeling here, which is left ventricular dilatation. In hypertrophy, the radius attempts to stay the same, and the thickness, let's say, doubles. So when you have increasing thickness with everything else remaining the same, what that does, if you increase thickness on Laplace law, that decreases left ventricular wall stress. So concentric remodeling is a bit of a protective mechanism in this sick heart in order to decrease the force that the LV has to generate. Oh, sorry. versus eccentric remodeling, so dilation, where you see increase in the radius while trying to maintain the same thickness of the LV wall. So you can see if the radius is increased, but everything else is maintained the same, that will actually increase the LV wall stress. So it's more deleterious for the left ventricle. So let's take a look at how this works in combination with different respiratory situations. So I'm going to orient you to this really nice schematic. The gray is the thorax, and the numbers in the top right are just pretend intrathoracic pressures. This is the left ventricle, and this is the aortic pressure. So again, the left ventricle must generate a force that can overcome the intrathoracic pressure in order to pump into the aorta. So it's do a lot of work to do that. In a spontaneously breathing, normal child, no lung disease, like fine, let's assume the intrathoracic pressure is 0. So the pressure that the LV has to overcome is 60 minus 0 equals 60. Okay, so that's like your baseline state. In a deep negative breathing, so a kid that has workup breathing, we haven't intubated them yet, but they're working to breathe, which means they're really creating even a greater negative intrathoracic pressure in order to overcome whatever lung disease they have. So that workup breathing is trying to mobilize all their accessory muscle use and their diaphragm in order to create a more negative intrathoracic pressure to support ventilation. When that happens, you can see that the intrathoracic pressure goes down. So now the LV must overcome 60 minus 20, so 80. It has to generate a higher pressure just to be able to eject blood into the aorta during systole. So the LV has to work harder in a child with deep negative breathing. If we've decided to intubate that baby, now we've created a positive pressure situation in the lungs. So now let's say that their positive pressure is 15. So the work that the LV has to do is 60 minus 15 is 45. So we've actually offloaded some of that work of the left ventricle in order to be able to pump blood into the aorta. And then finally, if we have a low SVR state, so like our most common hemodynamic physiology, really sepsis and neck, it makes sense to us that low SVR state means the LV doesn't have to work as hard. It has to generate less effort in order to pump into a lower afterload state. So that might be a good thing from a left ventricular perspective. However, obviously nothing works in isolation, and low SVR state that are pathologic like sepsis are problematic for other reasons. So it's not that it's a good thing for the LV to be in a low afterload state. Oxygen delivery will be affected from other perspectives from sepsis. So putting all this together, our preload, afterload, ventricular independence, everything, we can see that this impacts ventricular output throughout the cardiac cycle, as summarized here. Sorry about that typo. And it's really ventricular output that we can measure by echo very nicely. And we can sometimes see beat to beat variability or every couple of beats variability just related to respiratory cycle. Okay, does the mode of ventilation impact this at all? Well, very little data, not surprisingly in neonates, but I will draw your attention to this nice study that compared CPAP and NIPPV. In adults, it's a little bit more obvious that there are hemodynamic differences when adults placed on CPAP and NIPPV, but that doesn't seem to be the case in neonates. These echo findings looked at these two groups and found no difference in hemodynamic parameters. However, the pressures that were used in this study were quite low, like CPAP of 5, a MAP of 8 on NIPPV. These are probably lower than what we're actually using in real life in babies. And the other thing is our infants, if they're extubated and just hanging out on CPAP and NIPPV, they probably have optimized or near optimized FRC. So they might not be in a clinical situation where we will see massive changes in hemodynamics. What about invasive modes of ventilation? Well, there's some earlier animal studies that looked at conventional versus high-frequency ventilation and found that there's maybe some differences in outputs, in cardiac outputs based on the mode of ventilation. But this preterm study, this human preterm study, this was a trial that compared infants on conventional ventilation high frequency and found no differences in cardiac outputs and other hemodynamic parameters between the two. There was slightly higher mean airway pressure used in the high frequency group. So probably as long as the mean airway pressures are comparable, we're not creating massive hemodynamic changes with the mode of ventilation. Let's just run through in the last few minutes a couple of specific disease states where we can see these cardiopulmonary interactions at play. So RDS, obviously, specifically talking about the surfactant administration piece. Why do we want to give surfactant? Well, we have a poorly compliant lung with high surface tension related to surfactant deficiency. So we're trying to treat that with surfactant replacement therapy. That's what SRT stands for. And we're essentially trying to establish functional residual capacity. Again, that's the goal. So there's been some studies that have looked at pre and post surfactant administration and hemodynamic parameters and have found that surfactant administration in RDS improves pulmonary hemodynamics and right ventricular function. So it's probably a reflection of decreasing PVR that improves all those right-sided numbers. There's conflicting evidence about what its impact is on LVO. LVO can be improved if you have increased pulmonary blood flow, so increased left-sided return, or also unchanged if you're also decreasing right-sided pressures and allowing for more atrial level flow. That might not end up changing your left ventricular output, even though you're improving right-sided numbers. There's also some conflicting, evidence regarding increased ductal diameter with surfactant administration. It's probably not so much that the duct actually changes diameter, but there's more shunt volume when you decrease PVR, as well as more pulmonary blood flow, releasing more endogenous pulmonary vasodilators, and that has an impact on the actual blood vessel of the PDA. So essentially, surfactant administration, not just a respiratory drug, it also has hemodynamic changes, particularly in its improvement of right ventricular hemodynamics. Okay, the PDA, we talk, no need to go into great detail about this, but we talk a lot about pulmonary overcirculation. So we know that the PDA causes left to right shunting, which causes increasing pulmonary blood flow, and there's left-sided impacts when we see those chronic shunt exposed kids, they can have LA-LV dilatation. But this ends up having a back pressure into the pulmonary vasculature, so increased pulmonary venous pressure and pulmonary congestion. And in particular preterm pulmonary vasculature, which is very poorly compliant, not really able to tolerate this so much, we can see we see capillary leak and pulmonary edema. That's that West phase 4 or West zone 4 that we start to see. But of course, it doesn't occur in isolation because we also have heart impact as well. So this one we probably are more familiar with, how the heart and lung are directly affected with PDA. Hypotension, more a condition than a disease, but hypotension we can see in a lot of situations. And we will often treat with fluid therapy. That's typically our first line. This is the Frank-Starling curve, and this curve is very important for us in hemodynamics to understand the relationship between preload and stroke volume. But it also plays a role with lung disease because it is closely correlated to this curve, which is the Merrick-Phillips curve, which looks at extra lung interstitial fluid or lung interstitial pressures. So they're very closely tied. In infants that we give fluid boluses, if they are on this part of the Frank-Starling curve, they'll be quite fluid responsive. A fluid bolus will cause a dramatic increase in stroke volume versus the flat part of the Frank-Starling curve, a fluid bolus, that same fluid bolus, will not cause as dramatic increase in stroke volume. Those are less fluid responsive kids. However, if you look at the correlating part on the Merrick-Phillips curve, in the very fluid responsive part on Frank-Starling, they don't seem to have a big increase in their extrapulmonary lung fluid or in their interstitial fluid with fluid administration. But if they're less fluid responsive, they're on the flat part of the Frank-Starling curve, you'll see a dramatic increase in interstitial pressures within the lungs. So again, a hemodynamic intervention, or what we probably only consider a hemodynamic intervention, which is fluid boluses, which we give for blood pressures and macrocirculatory blood flow, has a direct impact on the lungs, which can have subsequent impact on the heart because, of course, PVR will rise in this situation as well. So we have to think about fluid boluses as a cardiorespiratory intervention. And then finally, septic shock. We can see in really sick kids with septic shock, hypoxemic respiratory failure, which this is a whole other talk, but we will think about many things, often pulmonary hypertension or maybe ARDS, which is a secondary surfactant deficiency. But this work that we published earlier this year, we found that infants with septic shock associated hypoxemic respiratory failure actually had lower indices of systolic and diastolic performance. So while we often will think clinically that septic shock is HRF and septic shock is a lung problem, intubate 100%, maybe even trial of nitric. It's actually often the heart problem that might just not be as clinically apparent. And so these need a different management strategy. So that was a very brief and very quick, it's only supposed to be half an hour, overview of cardiopulmonary interactions. I mean, the biggest takeaway here is in an individual patient, all of these factors will be at play, and these things will be evolving over time, because you might have a well infant on CPAP who's spontaneously breathing that evolves into a septic shock patient that's intubated, that's not breathing at all. And so all of these physiologic principles will come into play at one point or another over a course of an illness. So our job is at the bedside is to think about oxygen delivery starting from outside, like the atmosphere or the ventilator, and ending up at the tissue from an ATP perspective, and going through all those steps along the way in order to figure out where the problem is in order to optimize oxygen delivery. I've left you with some suggested readings. These are some great papers, a lot of them published very recently. And then Danny has written chapter in the Neonatal Questions and Controversies textbook, which is really definitely excellent reading. In conclusion, so heart and lungs exist within the same pressure chamber, so they're exposed to the same pressure, which means that if you do a heart thing, it'll affect the lungs and vice versa. A high MAP is different from excessive MAP. High MAP is a number and might be needed for a particular compliance of lungs. That's different from hyperinflation and excessive MAP, which means it's overdone for that particular lung compliance. Really, the goal is about establishing FRC. So one MAP might be, one baby might need a higher MAP than another, but as long as they're establishing FRC, that's optimal lung recruitment. And if you over-recruit or under-recruit, that can affect pulmonary vascular resistance and can subsequently affect pulmonary blood flow. Spontaneous respiration and mechanical ventilation have opposing impacts on cardiac blood flows. So consider ventilation as a tool in your hemodynamic toolkit. Sometimes it's something that can help or worsen your hemodynamic situation. Okay, thanks. Happy to answer any questions.
Thank you very much for that wonderful talk. Reminder, please put any questions you have in the Q&A. And then before we end the session, there's also in the chat, there should be a link to the eval or the QR code seen on the screen. While we wait for maybe a few questions to come in, wonderful talk. I think we so often forget how connected the heart and lungs are. In particular, it can be challenging when you're at the bedside and trying to determine what that optimal lung recruitment is for each patient to find that FRC. Really challenging when are you overexpanded, but anytime you try to wean, say the MAP, things get worse. So do you have any advice for the clinician at the bedside trying to find that optimal lung recruitment for the babies?
Great question. So I think number one, obviously we can't be x-raying these kids repeatedly to try to figure it out. And even when you do, x-ray for one thing is a snapshot in time. So it's only reflecting the physiology that you have in the moment. The other thing, there's also some literature that tells us that our typical, rules of how we determine expansion on x-ray, like the number of ribs, might not actually reflect FRC. So there's limitations in that tool itself. So one thing that we can use clinically is your CO2. If you are, we've talked about this before when we talk about giving nitric to the PPHN baby, and you have to open them up and you have to give them their surfactant or intubate them, mean airway pressure, whatever it is, in order to open them up first, or the nitric won't work. And one of the clinical markers that I'll use at the bedside is making sure my CO2 is normal. If the CO2 is in the 90s, I haven't opened up the lungs sufficiently, and I need to work on that first before starting nitric, because the nitric isn't going to get to where it needs to go. So CO2 is a helpful marker. You can do it on transcutaneous or just get a gas. Those are CO2 capacities in the NICU, unfortunately, because we can't get any other types of numbers, I guess, just given our limitations with their babies. So that's one thing. Potentially there's a role for lung ultrasound, which would be easier to get in the moment than doing repeat x-rays for these babies. And then we'll do lung recruitment maneuvers, which are helpful information at the bedside. So you have to be at the bedside to do this, and do this with in collaboration with the RTs. And you're at the bedside doing stepwise or incremental increases in mean airway pressure or in PEEP and seeing what the response is in the real time. At some point, when you've over-recruited or when you've reached that plateau point, you will see no additional benefit in either your CO2, your oxygen saturations increase, or your FiO2 decrease. And so you know that you've kind of reached FRC just below that. So those are some bedside tools that I would use.
Fantastic. Yeah. I feel like it's always a little bit more challenging when you're on the other spectrum of it, when you're like, do you have excessive mean airway pressure that's starting to play a role, and can be a little scary at times, but you said it exactly right. You have to be at the bedside assessing how these babies are, because you might wean your mean airway pressure by 1, and initially that baby might desaturate, but if you kind of hold there, let them kind of reequilibrate, then they can kind of, you might start to see your saturations go up. But I think a very key point that being at the bedside, seeing what is your patient doing, what are those markers like your CO2, and hopefully someday maybe lung ultrasound really playing a role in that. One of the questions we kind of have is the thought looking at high frequency oscillator and the NAVA effect on hemodynamics. I guess kind of going into that, do you sometimes see it where you kind of fall into that trap when we're on high frequency ventilation, where we start to maybe overshoot what that FRC is for our patients?
Yeah. So for one thing, there's no like wrong mode of ventilation. There might just be inappropriate settings or insufficient settings or wrong approach, but you can I would say that as an overarching statement, because nothing's ever black and white in the NICU. However, in order to understand what's the optimal mode, you have to understand the baby's physiology first. So HFO might be a nice, because you're basically providing a same distending pressure everywhere. You're giving whatever map you're giving and whatever frequency amplitude you're giving above that for ventilation, which will work nicely for babies with homogeneous lung disease, like the early RDS kids, for example, or babies without significant lung disease but have like apneas, or some central thing that you're intubating them for, where their lungs are more or less the same throughout. But the babies that have very heterogeneous lung disease, so like a PIE kid, for example, that you'll really see the impacts of ventilation on oxygenation. So if you choose a mean airway pressure in a baby with PIE, it might work for some components of the lung, but not for other components of the lung, which means that you might optimally recruit some and hyper expand others. And that's just the way that it would work with HFO. That's one of the, I guess, consequences of choosing to use HFO in diseased lung states like that. So in that case, we would use NAVA in our site, which is a whole other discussion, but we would use NAVA to basically allow the baby to drive as long as they're spontaneously breathing and they have appropriate diaphragmatic function, like they don't have central reasons for not breathing. They would be able to draw the amount. We would set a PEEP, but they could draw as much PIP as they want and need. And also there's synchronization, so it's different from a regular conventional ventilation mode. And we find that babies' oxygenation needs improve without hyper expanding these kids as we might with HFO, because you kind of just feel like you go up and up and up and up because you're trying to recruit this very under-recruited part of the lungs. But you can end up in a hyperinflated state if you're overinflated that emphysematous lung. And it's really hard to do that with HFO and PIE. So it's, yes, you can see that HFO can cause that. It can also, if we don't wean fast enough, once a disease has improved. So perhaps you've started HFO for severe RDS, for example. Now you've given the kid 1-2 doses of SURF and their lung compliance has improved, but you've left them on a MAP of 12. Well, at that point, that can cause hyperinflation, even if it didn't 6 hours ago. So their lungs are super dynamic. Another example would be like an AKI kid who would have significant pulmonary edema, so poor lung compliance during that time. So they're intubated on HFO, but now as they're peeing, you really should be weaning the MAP as they're alleviating their own pulmonary edema. So again, it's more a reflection in most cases of us being at the bedside and doing the due diligence for the child about adjusting the settings as their physiology changes.
Fantastic.
Okay, I see that people are starting to log in. It's 2:02, so hi everyone. I'm Gabrielle Altit. I'm a neonatologist based in Montreal, the Montreal Children's Hospital, and I will be co-chairing with Dr. Daniel Rios, who is at University of Iowa, these sessions on the foundation curriculum for TNE and neonatal hemodynamics from the Neonatal Hemodynamics Research Center. So it's really my pleasure to welcome you to this first session of the 2024-2025 academic year. Basically, I just want to give some heads up about the format that we will have for this current academic year based on the feedback we obtained from previous attendees. Basically, the trainees and junior faculty will join these lectures as panelists, and you are able to unmute and turn on your cameras to ask questions directly to our session speakers. For the seminar audience that are not part of the panelists, you are encouraged to place your question in the Q&A box so that we're able to ask these questions to our speakers towards the end of the first session. After the first session, there will be a small groups for the panelists that will be just for the panelists. The lecture is recorded, but the Q&A session following the lecture will not be recorded, so feel free to ask any questions that you may have. And there will be a link and a QR code to complete the session evaluation once the lecture is complete. So please fill the evaluation because we do look at it so that we can improve the content and really adapt it so that it tailors the needs of the learners that are part of this session. So I just want to acknowledge the fact that the neonatal hemodynamics and the TNE-NP foundation curriculum is supported by an unrestricted educational grant from Mallinckrodt Pharmaceuticals. And so with undue notice, I want to present our first speaker of this academic session, which is Dr. Patrick McNamara, who will be presenting on neonatal cardiopulmonary physiology. Dr. McNamara is a professor of neonatology and cardiovascular medicine and division director of neonatology at the Stead Family Children's Hospital in Iowa City, affiliated to the University of Iowa. Dr. McNamara has been, a force in our field and a pioneer of our field of targeted neonatal echo and neonatal hemodynamics. He's the current chair of the PAS Neonatal Hemodynamics Advisory Board and also of the American Society of Echo Neonatal Hemodynamics T-ECHO Special Interest Group. And he's the co-director of the Neonatal Hemodynamics Research Center. I think he's inspired many of us and taught many of us in so many ways through his academic session, his research, his generosity in sharing his knowledge and experience, and has contributed to support the care of so many vulnerable newborns across the world. So really thank you, Dr. McNamara, for joining us and sharing with us your wisdom. And I will open up the floor for your presentation.
Thanks, Gabriel. I don't know about wisdom, but I'll try and share some thoughts. Just let me know if you can see the slides.
Yes, but we can see them, and yes, perfect. We can see them well.
Okay, perfect. Okay, so it's very nice to connect with everyone for this afternoon session, the first of the curriculum, and I think this is probably a very good place to start. A lot of the time we get caught up in imaging and who should image and why they should image and et cetera, but the fundamentals of why 20 plus years ago, people like myself really pushed changing the paradigm is what we lacked in the NICU was a physiology-based approach to cardiovascular care. So for the next 30 minutes or so, we're going to talk about why hemodynamics is physiology. So some of you may have seen this paper, and if you haven't, I would encourage you to take a look at it. That Steve Abman and Phil Levy and I wrote on re-engagement with physiology because there are many existentialist threats to contemporary neonatology, but one of them is how far many neonatologists have moved away from thinking of physiology at the bedside how the approach to care is oftentimes very dogmatic, very algorithm protocol based, and it makes no sense. And what I'm going to talk about today is, what is our ground zero and how can we evolve beyond that ground zero? How can we re-engage with physiology and recognize that it is vitally important to have a fundamental understanding of the principles that govern, the neonate, the immature neonate, if we are to optimize the care of these babies. This has become my new most favorite slide, and I've introduced it to many presentations. And I would encourage you just for 10 seconds to look at the slides and to look at the black boxes and to look at the red text boxes. And think for a second, how many of these concepts or principles have I heard of? Can I relate the principles to the specific physiologic concept? And, if I were to do a test today all across the country and get neonatologists to complete this and to draw the lines between these boxes, many people will struggle to do that. And that's a problem because whether you're managing the lung, whether you're managing the cardiovascular system, these principles are vitally important. So what is our ground zero? Our ground zero is really terrifying, okay? Today, in the year 2024, in the vast majority of NICUs across the world, people provide a blood pressure-centric based approach to decision-making. The adjudication of whether you're well or unwell is based on arbitrary thresholds of blood pressure. And what that is cultivated, a symptom-based care approach to management. Second, most of our clinical trials, doesn't matter what the topic is, are trials based on convenience, okay? Can I recruit X number of patients within a certain time frame and make the trial very pragmatic to try to get patients into the trial without actually looking at the applicability, recognizing the broad variance in physiology that may exist within individual patients. And then finally, most people struggle with very infrequent or periodic echocardiography. And when it is done, most of the information provided to the neonatologists are based on an anatomy-based imaging assessment, a protocol that's designed for anatomy that is used to actually kind of provide some physiologic information. And oftentimes that information is very limited. So then it's no big surprise when we look at our ground zero, it's now very good. We have studies like this from Beaubaton, which suggests that, even if you treat low blood pressure, the babies don't do any better and may actually do worse. And that has caused a paradigm shift in some centers where many individuals will never treat blood pressure. It's considered perhaps not important because of the data that we have. And there's two ways to interpret this. Blood pressure is meaningless, or the approach to thinking about blood pressure, to thinking about what it means within individual patients, and a physiology-based approach to blood pressure is missing from our care. And I believe the latter is the more likely situation. Some of you will have seen this slide before. This is Reagan's survey across academic centers in the United States. This is not preterm babies, this is term babies, but there is massive inconsistency even in how we adjudicate what is normal versus abnormal. So if we don't necessarily know what is the standard of blood pressure to achieve, it's very difficult to actually study the impact of treatments for low blood pressure. As mentioned before, in many centers, people practice still in a very algorithmic-based approach. And if your target is to make the blood pressure number go up, okay, these type of algorithms may make the blood pressure go up. However, within this, there are many issues. There are one, if a therapy makes no difference, why do you keep increasing it? And why do you leave it on if it hasn't made any difference and so forward? But the other big issue within this is the fact that, in most centers today, people rarely perform echocardiography for infants who are hypotensive, okay? Again, a very blood pressure-based approach to care is what drives our care. And for some babies, this may be okay, but for many babies, it really doesn't make sense. These systems have evolved because of the lack of proximity to information that may actually help neonatologists make better decisions. So The second and the other important concept is, the adjudication of how reliable is blood pressure as a measure of how well you are, or how does it help you in making better decisions? And both of these babies in front of you were very sick in our NICU, but neither of them had low blood pressure. As mentioned before, most of the care has been based on arbitrary thresholds of mean blood pressure rather than gestational age. So concept number one, blood pressure does not predict cardiac output in a linear manner. Okay, here's some data looking at two surrogate measures of cardiac output. And what you can see is that the relationship is very nonlinear, okay, such that there are babies that have low blood pressure but have preserved cardiac output that may not require therapy, and vice versa. And more concerningly, there are babies in the NICU that may have a normal blood pressure or even a high blood pressure, but are in a low cardiac output state, and that's not necessarily recognized. So this relationship between low blood pressure or blood pressure and heart function is very tenuous. Just very briefly, just to identify the point, this was an infant born at 34 weeks gestation who was asphyxiated, initially had RV dysfunction, managed with dobutamine, got better, unfortunately had refractory seizures. The infant had new onset hypertension on day 7, okay? Blood pressure was 98/32, but had low oxygen requirement. The team did do a blood gas and demonstrated that the infant had evidence of elevated lactate with a base deficit. And when the echocardiogram was performed, you can see, although the blood pressure was not low, this infant had fairly significant LV systolic dysfunction. And when you look at the strain, globally was -6. Okay, so blood pressure or low blood pressure is not the only way to adjudicate the health of an infant. So why might this happen? Well, I think it's important to recognize that in the face of low blood pressure or in the face of low flow, as may exist in this infant here, who was potentially in a low cardiac output state first, the body responds to this by upregulating the renin-angiotensin system, which will lead to high levels of angiotensin II and aldosterone, which will lead to significant vasoconstriction. So the hypertension may be causal, but it also may actually be consequential. And I think one of the things that currently is missing in a lot of NICUs is we have prioritized low blood pressure and deprioritized normal to high blood pressure. And oftentimes when the blood pressure is high, people will look for an excuse. Oh, the baby's agitated or the cuff is the wrong size. But it's possible that the high blood pressure may be pathologic. To further emphasize the point, does resolution of low blood pressure mean pathophysiologic recovery? And this was a twin born at 28 weeks gestation who was hypotensive, got treated, and the blood pressure recovered. You can see 47/32, which is normal, but the infant persistently had elevated lactate. So an echocardiogram was performed, and you can see here that this infant had evidence of fairly significant RV dysfunction, and the quantitative measures were very abnormal. So recovery of blood pressure doesn't necessarily mean that the underlying physiology has actually recovered. We transitioned this baby to a more physiologically more approach to therapy with milrinone and low-dose epinephrine, and the infant recovered. So we need to evolve in our thinking. Blood pressure is important. It does mean something, but we need to think beyond just looking at the blood pressure and looking more comprehensively at hemodynamic stability. This study here from Frank van Bel's group emphasizes it quite nicely. And when they looked at the neurodevelopmental outcomes of hypotensive babies, what they found was no difference between the groups. However, the subgroup of infants with low cerebral NERs, potentially a measure of poor cerebral perfusion, were the infants more likely to have impaired neurodevelopmental outcome. So we need to potentially not just look for the cause, but also look at other ancillary ways to evaluate the physiology continuously, and the role of NERs and potentially providing additional supportive information is something we need to seriously think about. If you look at this algorithm here, physiologically, looking at the relationship between blood pressure, cardiac output, and vascular resistance, our research has focused just on this part. Does low blood pressure predict abnormal states of perfusion or abnormal neurohemodynamics and outcomes related to this, without recognizing that you may have variance in blood pressure, variance in cardiac output, variance in vascular resistance and autoregulation that may exist within individual patients and may actually change over time. So looking at one element is probably not going to give us the answer to find the holy grail to what is the threshold of interest. It's not likely to be an individual threshold of any individual metric. We need to think much more comprehensively about the physiology. So this used to be my most favorite slide. It still is kind of a very favorite slide because this is really the holy grail of what we should be doing in the intensive care unit with sick babies. Our goal is to optimize cellular metabolism. And when you change the paradigm to cellular metabolism, you now need to think of oxygen delivery and oxygen consumption. Oxygen delivery is dependent on the adequacy of hemoglobin, lung recruitment, and cardiac output, which is influenced by heart rate, preload, afterload, and contractility. Blood pressure is important, but it is no longer the endpoint of interest. It is a symptom, an additional symptom or metric of cardiovascular homeostasis. And to better provide care, we need to think of all of these in continuum. So let's think about some of these physiologic concepts. Well, step number one is to recognize that the heart is different, particularly in the most extreme preterm babies. And, we have a baby in the NICU at the moment today who we've been taking care of, who's born at 21 plus 0, whose heart is very different. It's very different in its architecture, very different in its functionality. A lot less muscle, the sarcolemma are much more scattered, thereby making it more susceptible to change. It's also important to recognize that, in taking care of these tiny babies, we're taking care of the fetus. So in utero, the heart will go through a series of normal adaptive states, and the normal adaptive state in the fetus is for the myocyte to proliferate. It undergoes hyperplasia, That's really, really important because if we intervene and have, let's say, states of prolonged hypoperfusion to the heart, or we give medications like lots of steroids, particularly at high dose, that will disrupt this process. By turning off hyperplasia, you end up then turning on hypertrophy, which means that you will have a heart that seems normal in size, but intrinsically it's not. It's got less myocytes. It's got less myocardial endowment. And is this part of the reason why these babies grow up to be adults with hearts that are smaller? We've actually got less myocytes there to support the circulation. So what are the differences in the neonate compared to the old child? Well, the first thing, this is the Frank-Starling law, which is the relationship between preload on the x-axis and contractility on the y-axis. And what you can see, unlike the adult, it is very flat unless you're at low rates of filling pressure. This is important because giving lots and lots of volume in a state of normal preload is not likely to improve contractility. There are some exceptions. The infant who has a malcompliant heart, such as hypertrophic cardiomyopathy, restrictive pericarditis, or infants like a Fontan circulation, which are passive, there may be benefit to having a higher preload to alter the Frank-Starling law. This is probably the most important principle that underpins a lot of what we do in the NICU, which is the relationship of afterload to contractility. Afterload is what you do in the gym when you bench press, when you squat. You place a load on the muscle, and the muscle is only able to tolerate that afterload if it's higher for a certain length of time. Just like we can't squat all day long, Our muscles will fatigue and they will fail. If you look at the image on the left-hand side, which is a study comparing the neonatal relationship to the adult relationship, on the x-axis is afterload, surrogate. On the y-axis is a surrogate of myocardial contractility. You can see that the slope of the line for the neonate is much steeper, confirming that the neonate for the same delta or change in afterload will have a much steeper drop in contractility. So the neonate, because of its immaturity, does not tolerate afterload well. We don't have a lot of data comparing the RV versus the LV. This is a cath lab study, which suggests that the RV on the left, which is steeper than the right, may have intrinsically more vulnerability to afterload. And that may relate to the fact that the fibers are very different in their architecture. And I think you'll get a lecture about that at another date. When is this important? Well, when you're born. when you eliminate the placenta, when the duct closes, there's a change in afterload to both the RV and to the LV. Managing babies with both acute and chronic pulmonary hypertension places an afterload change on the RV. Closing the duct in the cath lab places an afterload increase on the LV. This is the force frequency relationship, which is something that people don't talk about and something that's very unfamiliar to most neonatologists. It's the relationship of heart rate to contractility. And in a normal preserved relationship, as heart rate goes up, contractility will go up. But to a point, you can't have heart rates of 500 and cope. The neonate will fail because tachycardia will lead to suboptimal diastolic filling time, which will ultimately impact coronary perfusion. So extremes of tachycardia will be harmful. But where this is very relevant is when you're giving medications, okay, to try to optimize heart function. If the medication, which does increase heart rate, does not lead to a synergistic improvement in contractility, you end up with this blunted force frequency relationship. Okay, and that's where serial echocardiography and critically ill babies to look at how does the heart respond to changes kind of as you increase your inotrope, particularly those that have a lot of chronotropic effects. This is potentially very bad because now you've had no gain in terms of function, but you've made the patient more tachycardic, which will further compromise coronary perfusion, leading to decrease in perfusion of the heart. This is a study basically looking at the effect of heart rate on myocyte contractility. And as the cycle length decreases, as the patient gets more tachycardic, the older infant has a more positive response in terms of its contractility than the newborn does. So we have to be very careful about persistent or extremes of tachycardia. This is Robert Hooke, and Robert Hooke is famous for Hooke's law, okay, which is looking at compliance. And compliance really is how does pressure change as volume changes. And this is very relevant in the hypertrophic heart, okay, which is poorly compliant. And if you look at the graphs on the top right, looking at how volume changes or how pressure changes with volume, if there's very poor compliance, okay, for a smaller change in volume, but a much higher increase in pressure. Unlike the very compliant heart, whereas volume goes up, pressure changes to a much less significant effect. And this is very, very important in the hypertrophic heart and when we're trying to maintain effective cardiac output, in which you've got restrictive compliance of the heart. The next concept is the Wynne-Kessel effect, which again is something that we really never talk about, but it actually is very, very important. And the Wynne-Kessel is kind of comes from kind of fireman lingo, in which the Wynne-Kessel ensures a continuous flow, so that blood, which is coming from the pump, doesn't come in spurts. Because when you're trying to put a fire out, you need the water to be continuous. Similarly, from a cardiovascular perspective, when you empty blood out of the aorta, it is pulsatile flow. There's very little diastolic flow. But by the time you get to the vessels, like here, this is a celiac artery, you can see that there's flow in systole and diastole. What the Wynne-Kessel effect relates to is the compliance of the vessels. What it does is it dampens the flow such that end organs do not receive high velocity pulsatile flow that can damage them. It smooths the flow out so that they get flowed both during systole and diastole. We don't know the relevance of this to the neonate, but it's possible that there may be premature aging in the aorta and peripheral vessels because of many of the things that we do to babies. We just don't know about it. In adults, and particularly geriatric patients, if you lose the Wynne-Kessel effect, this is why people end up getting retinopathy of prematurity and kidney disease and so forth. RV-LV interaction is important. This is nicely demonstrated by Anna Masolo's study here, showing that the RV and the LV are completely interrelated, that if you have compromise to one ventricle, it may have a secondary effect on the other ventricle. So again, important consideration. So how do we apply these concepts? Well, first, to recognize that the fetal circulation and the postnatal circulation are very different. The PFO modulates brain perfusion. The PDA modulates flow to the systemic circulation, such that after birth, there are major changes in loading conditions that occur. On the right side, preload is reduced as you decrease blood return from the placenta to the right heart. Afterload also decreases on the right side as pulmonary vascular resistance falls. The improvement in pulmonary blood flow leads to an improvement in preload to the left heart. And on the left side, afterload will increase as you remove the low resistance placental circulation from the left heart. And it's important to remember these things when you're dealing with sick babies. So when you're born, saturations are not 100%. They take 5 to 10 minutes to increase, and that's because there are changes in physiology that occur. It takes time to recruit the lung. PVR will fall, and the RV needs to adapt to the changes in loading conditions, and that doesn't occur immediately. It takes time. Here's some data from the Abe Rudolph's canine experiment demonstrating it takes up to 2 weeks for your pulmonary vascular resistance to fall. The other important consideration in the early neonatal period is the relationship between PO2 and pulmonary vascular resistance. And what you can see here is that kind of increasing the PO2 well above 60 millimeters of mercury really has very little added benefit on pulmonary vascular resistance. But when you drop your PVR below 50, you can see a fairly significant increase in pulmonary vascular resistance. As mentioned, the RV takes time to adapt. This is some work from Amish Jain's normative data. And you can see compared to 30 minutes versus 24 hours, that both TAPSI and RV strain and FAC increase significantly. So there's an adaptation that occurs, which is kind of interesting because when we look at things like HIE, we look at the preterm babies and we screen them with echo, the RV seems to be the ventricle that's much more vulnerable. That RV dysfunction is much more common in these disease states in the early neonatal period. So important to think about. What about the relationship between pressure and blood flow? So as vessels decrease in their diameter, resistance will increase and flow will decrease. And this is the relationship between pressure and flow. Pressure is flow times resistance with atrial pressure. And whether you're talking about kind of electrics or talking about geology, this has been defined in a very similar manner. How do we understand these concepts? Because traditionally, we oftentimes automatically think that elevated pressure is driven by elevated resistance. And this is a nice case. I don't know why the image is not working to demonstrate the case of an infant who was acutely hypoxic, had an echo at another institution, which demonstrated kind of that the infant had kind of suprasystemic pulmonary hypertension. The baby was given nitric oxide and got sicker, developed severe lactic acidosis. And kind of when the baby came to our center, when we performed the echocardiogram, what we demonstrated was the infant did have suprasystemic pulmonary hypertension, but had high flow, had very high right and left ventricular outputs. And when we went on and further did imaging, we demonstrated that the infant had an arteriovenous malformation of the brain. So important to recognize that pressure is not just driven by resistance, it's also potentially driven by flow. And in this situation here, where you've got a giant vacuum cleaner in the brain, the right to left ductal shunt is important to supply blood to the vital organs. And the baby became anuric because we limited this right to left ductal shunt by further decreasing flow. So important to recognize that elevated pressure may be of resistance origin. These are situations in which resistance is high, flow is low. Drugs like nitric oxide are likely to be beneficial in this situation. However, flow-based situations, you have the opposite effect, in which you already have got adequate pulmonary blood flow, and by further decreasing pressure, you're not likely to have any benefit in these type of scenarios. This is also exemplified. Again, you're going to have a talk on CDH. There are two types of physiologies. The classic resistance-mediated physiology, where you've got a right to left ductal and atrial level shunt, may benefit from drugs like nitric oxide. But the left heart phenotype, in which the oxygenation difficulty results from pulmonary venous hypertension and is exemplified by a left to right atrial shunt, is not likely to benefit from nitric oxide. So understanding the nuances of the physiology is vitally important in these particular scenarios here. So when thinking about pressure equals flow times resistance with atrial pressure, it's important to recognize that there are diseases, that may benefit from vasodilators, but may be harmed by vasodilators. We've not talked about the left heart phenotype very much, but that elevated pressure may be driven by resistance, may be driven by excessive flow, or may be driven by left atrial hypertension, like the CDH babies with LV systolic dysfunction. And the disease really requires a much more precise based approach to therapy. Just to end up very quickly, what about shunts? I'm not going to go into too much details, but again, this is the Hagen-Poiseuille principle, which is based on the fact that flow in a vessel must be Newtonian, laminar, non-compressible, and non-accelerating. Flow is determined by the pressure resistance, the diameter of the vessel, the viscosity of blood, and the resistance of flow, okay, as demonstrated here. So when you're thinking about babies with PDA, okay, the care of these babies is not just about a drug to vasoconstrict, but anything that'll influence viscosity, pressure gradient, is going to influence flow and potentially modulate whether the ductus is likely to close or not. The problem is we don't have a lot of evidence for the Hagen-Poiseuille principle, okay? Intuitively, carbon dioxide is a pulmonary vasoconstrictor and a systemic vasodilator. Oxygen does the opposite effects. We don't have much evidence, actually, physiology-based evidence, that these things actually do play a major role. It makes intuitive sense based on our understanding of single ventricle physiology. The effect of PEEP on these things, there is some data that it benefits LV transmural pressure, may modulate flow across shunts, but not a lot. And really, we've got next to no information on viscosity. The final thing I want to mention to you is the relationship between the heart and the lung, okay? Traditionally, we put things into buckets. Blood pressure, heart rate, and urinary output are the heart symptoms. CO2, low sats, respiratory rate are the lung symptoms. So that when we've got elevated CO2, we will naturally think about lung recruitment, tidal volume, but how often do we think about, is this carbon dioxide elevated because we've got poor RV function or poor pulmonary blood flow? I learned this relationship the hard way. The baby that got referred to us kind of when I was in Toronto, a very sick baby, born at 27 weeks, came to us with severe hypoxemic respiratory failure, had a chest x-ray that was supposedly normally recruited. The PO2 was 12. Nitric oxide and the oscillator were wheeled in like husband and wife. When I actually performed the echocardiogram, I don't know if this is going to play here, I could see a completely empty ventricle. I could not see the pulmonary veins. The flow was extremely limited in the pulmonary veins. And I asked the RT to come and take the baby off the oscillator and handbag the baby while looking at the flow in the pulmonary veins, and it was like a tap that was turned on. Okay, so this relationship between the mechanical ventilator, the dangers of hyperinflation is really important. And that was first described by Stephen Hales back in 1733, when he looked at the horse model and demonstrated a drop in blood pressure during inspiration. So it's really, really important to recognize that what goes on with the lung and what goes on with the heart are completely interdependent. And there's a pressure gradient between the systemic circulation and the right atrium that's important in spontaneously breathing people. When the diaphragm collapses, intra-abdominal pressure increases and right atrial pressure and pleural pressure decreases. But when you actually ventilate a patient and you increase intrathoracic pressure, you will actually limit this pressure gradient from the systemic to the pulmonary circulation, which can be really harmful in patients with RV dysfunction or preload-dependent circulations. The other thing that's really important to recognize is that lung inflation has another very important effect on pulmonary vascular resistance and then secondary effect on heart function. So this is the U-shaped curve, which shows that when you're very hyperinflated on the right side here, pulmonary vascular resistance will be increased. I would also argue that when you have a waterlogged lung from severe edema that sometimes you see in these babies with anasarca, the same effect will occur here. And on the opposite, when you're completely de-recruited, pulmonary vascular resistance will also increase. We try to achieve this normal FRC. And these things are also very important, in many of the disease states that may be harmful. High afterload may be harmful in pulmonary hypertension or RV dysfunction, but a little bit high afterload or PVR may be helpful in balancing single ventricle patients or patients with PDA shunts. Okay. So I'm going to stop there. I think I'm at my 30 minutes. And I'm going to end with basically, we're at a crossroads, okay? Trials have failed. 100% of them have failed in neonatal hemodynamics because we've not done due diligence in characterizing our disease states, understanding the physiology, recognizing that if we are to truly make a difference, we have to define the population, understand the disease, do the pharmacology of how drugs work, and then choose outcomes that actually make sense. And then also recognize that there's a whole massive variance in care that goes on that we don't even measure in the trials that may impact our response to therapy and influence our outcomes. It's really, really important that all of you, go back to basics, re-engage with physiology, ask the question on rounds, why are we doing what we're doing? If something's not working, stop it, try something else. And really, our ethos is, we can provide care, but to provide the best care, it requires enhanced diagnostic precision, careful integration of the relevant physiology, appraisal of therapies. We had a baby on the NICU 2 days ago, profound heart dysfunction. We echoed the baby kind of 3 times within a 6-hour time period to try to refine the physiology, which was very dynamic. So I'm going to stop there, and I would be more than happy for questions.
Thank you so much, Dr. McNamara, for this outstanding review. Definitely the cornerstone of everything we're doing at Bedside, and so important for the audience to incorporate this as we're starting this new year of the curriculum. So I think now we're gonna stop the recording and start the Q&A session. Community. So I'm gonna share my screen. Hopefully you see my presentation. So today I was tasked to talk about some of the hemodynamics aspect of the disease of CDH. And my disclosure are really relevant to the aspect that there's really just very limited trial evidence in congenital diaphragmatic hernia. And a lot of what we have are based on important research that has been done that remain mostly observational and physiological. And I still think that, when we have very critically ill children in front of our eyes, we need to act with the best evidence. And that's why I think as a community, we strive to give that kind of great and comprehensive care. Otherwise, I don't have any disclosure relative to the content of this presentation. So at the end of this session, my hope is that the participant will be able to explain some of the concepts related to acute pulmonary hypertension phenotype, LV dysfunction phenotype, and as well as recognize some of the shifting cardiovascular phenotypes in the context of the cardiopulmonary interaction, how to address them, and how to implement treatment strategies. I just want to, I'll mention that we do have at the level of Canada a collaborative that has worked together with the Delphi process to outline some of the best practices in order to offer some degree of protocolized care. And that obviously includes a large component of the hemodynamics evaluation and hemodynamics care. And recently, as you all know, there's been the new targeted neonatal echo guidelines that just got published in the Journal of American Society of Echo, which also integrates a lot of the concepts related to the standardization of hemodynamics assessment in the context of CDH. And so the guidelines are available through the portal of NeoCardio Lab. You can scan the QR code, and I'll put my slides, which contain a lot of the graphs and a lot of the recommendation as well through the portal so that you'll have access to these slides at the end of the presentation. So congenital diaphragmatic hernia remains an orphan disease. It's considered to be 2.6 out of 10,000 total births. And we know that, it manifests with a lot of the abdominal content herniating into the thoracic cavity, creating possibly an element of compression, which alters growth of the organs that we have in the chest and probably also alters the functionality of these organs herniating into the chest, such as a portion of the GI tract. And so what we know from autopsy studies is that the lungs that are being developed into this abnormal state leads to really an abnormal architecture at the level of the parenchyma, probably also at the level of the vessels. And that's really diffused to the entire lung. It's not just like a, one lung that gets compressed and because of that there's problem. It's actually been shown that both lungs are problematic, that there's a component component of pulmonary hypoplasia. And more, we realize that the chest being impacted at large, there's issue with restrictiveness of the chest, there's issue with scoliosis, but there's also issue of the heart, which is also an organ that is essential to the chest. And so I'll put some of these graphs that are truly wonderful and made by Dr. Satyan, who's been a strong advocate for pushing the research in the field and space of CDH. And so we had recently published this review where I think he cornered that